All right, today we're jumping into a topic that is absolutely essential for every medical student to get their head around: pelvic fractures. Look, this isn't just about some broken bones. This is a super high stakes area in trauma care, where the decisions you make can literally mean the difference between life, death, or a permanent disability. So let's break down how to make the right ones. Right off the bat, you have to appreciate the gravity of this. When we're talking about complex pelvic fractures, we are talking about a true lights and sirens emergency. The biggest, most immediate threat isn't even the fracture itself, it's the massive internal bleeding that can spiral into hemorrhagic shock in minutes. So, what is it that makes these fractures so incredibly dangerous? Well, the answer really lies in the unique anatomy of what we call the pelvic ring, and the two very different ways that its integrity can be completely shattered. The key concept, the thing you have to burn into your memory, is the ring. You can't think of the pelvis as one big bone. It's a structural ring, right? Formed by the hip bones and the sacrum. The entire stability of your core hinges on this ring being intact. So when a fracture breaks that ring, it becomes unstable, and that's when all the serious problems kick off. What's interesting is that pelvic fractures have what we call a bimodal distribution. On one hand, you've got your high-energy trauma, major car crashes, falls from a significant height, and these tend to happen to younger patients. But on the complete other end of the spectrum, you have what seems like a minor fall in an older, maybe osteoporotic patient, which can cause an equally devastating injury. So you have to keep your suspicion high in these two totally different groups. Okay, so you've got a patient who fits one of those profiles. How do you actually diagnose the injury? Well, it's a very systematic process. You're going to move logically from what you find at the bedside all the way to advanced imaging. The pathway is pretty clear. You always start with your hands-on clinical exam, looking for those key signs. A really critical part of this is gently evaluating the stability of the ring itself. From there, you'll get an X-ray to confirm. But listen, for any injury that looks complex, you're not stopping there. You are moving straight to a CT scan to see the whole picture. So on your exam, this is exactly what you're hunting for. Obviously, there's going to be localized pain and probably a hematoma, but the real key is to gently, and I mean gently, assess for instability. If you apply a little pressure on the symphysis and feel pathological movement, that's a huge red flag. This could mean you have an open book fracture, where the pelvis has literally sprung open. And why is that so bad? Because it dramatically increases the volume of the pelvis, creating this huge potential space for blood to just pour into. But let's just pause for a second. We found an unstable bony injury. Great, but what are we really worried about in those first few critical minutes? What are the true immediate threats to this patient's life happening on the inside? This is the answer. Those sharp, unstable bone fragments basically become shrapnel. The number one concern is a tear of the major iliac vessels, which can cause liters of blood to hemorrhage into the retroperitoneum. But it doesn't stop there. You have to actively hunt for damage to the bladder, the urethra, the rectum, and the sacral plexus, which can leave a patient with awful, permanent nerve damage. And this is exactly why the CT scan is absolutely non-negotiable. An X-ray is great for seeing the bones, sure, but a CT with contrast? That shows you the soft tissues, the blood vessels. It lets you see that giant retroperitoneal hematoma. It can even show you active bleeding, and it gives you a 3D map of the whole disaster zone so you can actually plan your surgical attack. Okay, so we've got our diagnosis. Now what? How do we manage this? Well, the entire treatment strategy is dictated by one single thing: the stability of that pelvic ring. You can really split this into two very different pathways. For simple, stable fractures, think an isolated break of the pubic rami, the treatment is actually conservative. We're talking bed rest for about 3 weeks. But for a complex, unstable, or displaced fracture, that's a surgical emergency. It requires immediate, aggressive intervention, usually with a whole team of trauma specialists. And in those complex, scary cases, the algorithm could not be simpler. Hemorrhage control is the absolute #1 non-negotiable first priority. Your patient can bleed to death long before that fracture even thinks about healing. So how do we stop the bleeding? It's a coordinated, multi-pronged attack. First, you're hitting them hard with blood products through a massive transfusion protocol. Second, you stabilize them mechanically. You apply a pelvic binder or sling correctly over the greater trochanters to close the book. This reduces that pelvic volume and helps tampen out the venous bleeding. And third, if there's still arterial bleeding, you call in your friends in interventional radiology. They can go in, find the bleeder, and embolize it from the inside.
Once the patient is hemodynamically stable, and I mean only when they're stable, do we then move on to definitively fixing the fracture. The goal here is just to restore the integrity of that pelvic ring. This can be done with internal fixation, plates and screws, or sometimes with external minimally invasive fixators. Okay, let's boil all of this down. If you're going to remember anything from this, here are the absolute critical take-home messages for managing a pelvic fracture. First and foremost, never, ever underestimate an unstable pelvic fracture. You have to treat it with the same urgency as any other major life-threatening trauma. This is not just an ortho problem, it's a resuscitation problem. Second, always remember that the bone is just the container. It's what's inside the container that's often more dangerous. You have to maintain a super high index of suspicion for those devastating injuries to vessels, organs, and nerves. Go looking for them. And finally, the sequence of your priorities is not a suggestion, it's a rule. Resuscitate and control the hemorrhage first. Stabilize the patient. The definitive bone fixing comes later. Just remember this: hemostasis over osteosynthesis. Stop the bleeding before you fix the bones. So I'll leave you with this to think about. The next time you're in the ER and that major trauma call comes in, how are you going to take what we've talked about today and put it into action? How will you systematically assess for and then manage a suspected pelvic fracture to give your patient the absolute best shot at a good outcome?